Welcome to the deep dive. Today we're tackling normocytic anemia.
Yep, getting straight into it.
So basically, this is anemia where your red blood cells are, well, normal-sized, but something's still wrong with oxygen transport.
Exactly. It's a common finding, so definitely worth revising. We're going to run through the definition, causes, risks, the mechanisms behind it.
Diagnosis, symptoms, management, the whole lot. Really high-yield stuff for revision.
Absolutely. Let's make it clear and concise.
Okay, so definition first. Normocytic anemia. Anemia, yes, but the mean corpuscular volume, the MCV, is normal.
Right, so the size is okay, but despite that normal size, there's an issue. Either not enough cells, they don't live long enough, or maybe they're not functioning quite right.
Leading to that reduced oxygen carrying capacity we mentioned.
Precisely. I like the mnemonic. Normocytic and no size issue, problem elsewhere. Helps frame it, you know?
That's a good one. Problem elsewhere. So what are those elsewhere problems? What causes this?
Well, it's quite a broad range, actually. A big one is chronic disease, think chronic kidney disease or ongoing inflammation.
Okay.
Then you've got bone marrow disorders, like aplastic anemia, where the factor itself isn't working properly.
Production issues.
Exactly. Then hemolysis, where red blood cells are destroyed too early.
Breaking down too fast.
Correct. And interestingly, sometimes nutritional deficiencies can show up this way, at least initially, or if you've got a mix of deficiencies. Iron, B12, folate, they usually cause micro or macrocytic.
They can sometimes present as normocytic.
Yeah.
Okay, good to know.
Yeah, it happens. Also, hormone problems like hypothyroidism, certain drugs, and of course, acute blood loss, like after surgery or trauma.
Wow, okay, that is a wide net. That mnemonic might come in handy. What was it again?
CHBNHA, chronic hemolysis, bone marrow, nutritional, hormonal, acute blood loss.
CHBNHA. Got it. So given those causes, who's particularly at risk?
Well, the risk factors really tie back directly to those causes, don't they? So a family history of anemia or blood disorders is relevant. A personal history of chronic kidney disease, inflammatory conditions, or known bone marrow issues, taking certain medications, sometimes poor diet, although that often links back to the nutritional side.
Right.
And, certain ethnic backgrounds might have higher rates of specific underlying conditions, and older age is often associated with more chronic diseases.
So it's quite diverse. Now, pathologically speaking, what's actually going wrong inside the body?
Again, it varies hugely with the cause, but you can boil it down to a few core processes, either decreased red blood cell production.
Like in CKD or bone marrow failure.
Precisely. Or increased red blood cell destruction.
Yeah.
That's your hemolysis.
Right.
And sometimes it relates to ineffective use of nutrients, though. As we said, that often leads to other types of anemia unless it's an early or mixed picture.
Okay. So when a doctor sees normocytic anemia on a blood test, what else is on their mind? The differential diagnosis.
Yeah, absolutely crucial. First, you want to be sure it's not just an early stage of iron deficiency, which would become microcytic, or B12 folate deficiency, which would become macrocytic.
Rule those out.
Rule those out or confirm if they're contributing. Then you think through those broad categories again. Chronic diseases, bone marrow disorders, hemolysis, maybe endocrine issues like thyroid problems.
How common is this specific type, normocytic anemia?
It's tricky to give a single number for normocytic anemia itself because, it's more of a description based on cell size than a specific disease.
Right. It's a signpost to other conditions.
Exactly. So its prevalence just reflects how common its underlying causes are. It affects all ages, sexes, ethnicities, but the frequency depends entirely on the population and what underlying conditions are prevalent there.
Got it. What about symptoms? What might someone actually feel or notice?
Often it's the classic anemia symptoms: fatigue, feeling weak, looking pale, maybe getting short of breath easily.
The usual suspects.
Yeah. Rapid heartbeat, dizziness, headaches, trouble concentrating, cold hands and feet. If it gets really severe, you might even see chest pain or palpitations.
And does the presentation change depending on the cause?
It can, yes, and also depending on how quickly it develops and how well the body compensates. Here's a quick scenario. Young adult, tired, looks pale. FBC shows hemoglobin 9.5, MCV 92. What's the initial classification?
Hemoglobin's low, MCV is normal, So normocytic anemia.
Bingo. That's the starting point.
So how do you investigate from there? How do you find that underlying problem elsewhere?
The workup starts with that full blood count, confirms the anemia, confirms the normal MCV. Then a peripheral blood smear is really important. Looking at the cells under a microscope can give big clues.
What kind of clues?
You might see signs of hemolysis or abnormal cells suggesting a bone marrow issue, things like that. Then a reticulocyte count tells you how well the bone marrow is responding, trying to make new cells.
Okay.
Iron studies, B12, folate levels are usually done fairly early to rule out simple deficiencies as the main driver.
All right, check the basics.
Absolutely. And then, based on all that and the clinical picture, you target further tests. Kidney function tests, inflammatory markers like CRP or ESR, maybe thyroid function, and in some cases, you might need a bone marrow biopsy.
Right. Really hone in on the suspected cause.
Oh.
So once you've figured out the why, how is it managed?
The management is all about treating that underlying cause. That's the absolute key.
Treat the cause, treat the anemia.
Essentially, yes. If it's a chronic disease, manage that condition better. If there's a nutritional component, supplement iron, B12, or folate as needed.
Makes sense.
Hormone issues, hormone replacement like thyroxine for hypothyroidism. If the anemia is severe and causing significant symptoms, blood transfusions might be needed for immediate support.
And managing complications too, presumably.
Yes, managing any complications arising from the underlying condition itself is part of the overall picture.
Okay. What about the outlook? The prognosis?
Highly variable. It really depends on the root cause, how bad it is, and the person's general health.
So, no single answer.
No. If you can successfully treat the underlying condition, say, manage the chronic inflammation, or cure an infection, the anemia might completely resolve. Excellent prognosis in that case.
But for chronic conditions?
For things like chronic kidney disease or certain bone marrow disorders, long-term management of both the condition and the anemia might be necessary. So prognosis can range from excellent to, unfortunately, quite poor, depending entirely on that primary diagnosis. Complications also track with the underlying cause and how severe the anemia gets.
Right. So wrapping up, the main takeaway.
Normocytic anemia. Red cells look normal in size, but don't be fooled. It signals an underlying problem with their production, lifespan, or maybe function. Finding and treating that root cause is everything.
Nicely put. Remember that mnemonic? Normal size. Now what's the story?
Perfect.
Think broad categories. Chronic, hemolysis, bone marrow.
Nutritional, hormonal, acute blood loss. CHBNHA. That's the framework.
Perfect. And if you want more high-yield MSRA revision resources like this, definitely check out pastthemsra.com.
And for some great free materials as well, head over to freemsra.com. Hope this deep dive was useful.
Thanks for joining us.